sudah mendengarkan dua presentan dan kita akan sampai kepada our guest speaker from Turkey, our friend from Turkey, Professor Kerem Bilsel, that come to our first webinar this evening. I would like to read his CV. Professor Kerem Bilsel has training in orthopedic and traumatology in Istanbul University, Istanbul Medical School, and then he continued with the fellowship for shoulder and elbow surgery in Japan and also in South Korea. So a lot of our friends here, also the alumni from Japan and South Korea. Professor Kerem Bilsel is the European Certified Board Orthopedic Surgeon that specializes in shoulder and elbow surgery. He is the Secretary General of Turkish Society of Shoulder and Elbow from 2017 until this year, 2021. And he's working now in Besmialem Fakih University Medical School, Orthopedic and Traumatology Department in beautiful city of Istanbul. Istanbul is a very beautiful city. I've been there for 3 times and always amazed by the beautiful of the Istanbul. But this evening, Professor Kerem Bilsel will share to us about the shoulder instability problem. Please, Professor Bilsel.
Thank you very much, Dr. Andri, for your kind introduction. First of all, I would like to send my condolence to the Indonesian people for the aircraft crash in last week in Indonesia. I am very sorry. I hope it will be nice and good days after this crash and the COVID situation as well. So first, I would like to thank the kind invitation for the Indonesian Orthopedic Society President, Professor Edi Mustamsir. And also, I would like to thank for the kind invitation for the Professor Hermawan, the President of the Indonesian Shoulder and Elbow Society. And I would like to thank the moderators and co-moderators for organizing this webinar. So my topic is the current treatment of anterior shoulder instability. So as the previous speaker told about perfectly the patterns and classification of the glenohumeral instability, I would like to say that this is a patient-specific situation because this is a dynamic process, and we have to see all the variants, the etiology, the mechanism, the direction, the age, activity, the expectation of the patient, and the bone loss for going the best fit treatment for our patients. As we know, the most common complication after the surgery we make for this glenohumeral instability is the recurrence. And it is about between, when we look to the literature, it's between 0 and 50. It's a huge number of rate. So we need to be careful about our option for the treatment. So when we look for the risk factors, the main risk factor, as the Dr. Arisna told about us, the bone loss. The bone loss is the key risk factor for the glenohumeral instability. We know it from the paper of Burkhardt and De Beer from 2000, the arthroscopy journal. If we have the glenoid bone loss, if we have the pear-shaped glenoid, we will have a recurrence rate more than 80%, maybe 80% after making a Bankart repair. So the glenoid bone loss limit for us, we know from the Itoi's cadaveric study, the limit was the 21%. But in the meantime, when we look for the new studies, we can see that the critical limit will go to the 15% or Now, for the collision athletes, for the contact athletes, it can be 13 or lower than 13% of bone loss. But the glenoid bone loss, if we have lower than 20%, we go safely for the soft tissue injuries. But if we have more than 15 or 20% of glenoid bone loss, we have to choose some bone block surgeries like coracoid bone block or iliac crest autograft or structural allografts. We know this ICSS, the Instability Severity Index score described by Pascal Boileau. It is very useful. We have to see and we have to evaluate our patients with this recurrence risks. So the main factor is age, the sportive activity, the hyperlaxity, and the radiologic measurement of the bone loss. First, I will talk about the arthroscopic repair, Bankart repair. As you know, in the past, it was done by open surgeries, but nowadays it become more popular and the popularity has increased with the arthroscopic procedures. Because our experience and the technology go with the minimal invasive surgery, so the open surgery will decrease and the arthroscopic surgery will gain the popularity and the recurrence rate will grow up with the 3 or 5%. So we can use some knotless anchors, as you see in the video, or we can use the conventional type knotted anchors. This is an example of one of my patient, 24 years old, second dislocation, basketball player. The ICSS score is 3, and we choose for the Bankart repair for this patient in a lateral decubit position, as you see in the video. So I would like to show you the Bankart lesion in the 5 o'clock position, and we evaluate the heel sacs is not deep and medialized, so we'll go for the Bankart repair. The key point for the Bankart repair is to release the capsulolabral tissue until the level of the 6 o'clock. So we need to release it because of getting the bumper effect after our repair. And we first put our first anchor to the 5 o'clock from the subscapular portal that we call 5 o'clock portal. It's sometimes risky, but we need to be careful to pass through the subscapularis muscle. And then we pass our sutures, and then we use here the knotted anchors, as you see, and we got the bumper effect after closing also the middle glenohumeral ligament on that repair. So in our university, our protocol for the arthroscopic Bankart repair is to, if we have dislocation episode lower than 3, if we have young patients lower than 25 years of age, if we have lower than 15% of glenoid bone loss and good capsulolabral quality, and also for the first dislocation in athletic shoulders, we go for the arthroscopic Bankart repair as well. The second procedure is heel sacs remplissage. As you know, the remplissage is a French word. It means that in French, to fill. We fill the heel sacs valley with the infraspinatus capsulotendinous tissue. This is a capsulotenodesis of the infraspinatus in the heel sacs valley. In the literature, we have good, significant, good results. Approximately 6% of the recurrence after this procedure. But when we look to biomechanical studies, we can have some restricted range of motion. But these studies are time zero studies. So if we put the anchors too medial, just nearby the cartilage, we have significant restriction of external rotation. As you know, the glenoid tract from Itoi studies, you can use also this measurement in your practice. Honestly, I don't use it because I'm working in a very busy hospital. So, but if you do some studies, if you want to clarify your results, you can use the glenoid tract as well. When we use Hill-Sachs Remplissage procedure, there are some steps. First, you have to put your anchors and you have to pass your suture from the labrum without knotting. And then you go for the Remplissage anchor placement and suture passage from the capsule and infraspinatus tendon. And then at the end, before Remplissage, you finish with the Bankart repair and go for the Remplissage. This is another patient of mine, 25 years of age, male. There's no glenoid bone loss, as you see in the en-face view of the CT scan. We go for the Hill-Sachs Remplissage. As you see, we put our anchor just in the middle of the valley. We don't go too much medially or laterally in order to have the good range of motion after the surgery. And we pass with the suture lasso our sutures from the capsule and the infraspinatus tendon. And then we go up to the subacromial space in order to see our sutures in the subacromial bursa. And then we tie our sutures to make it good compression on the Hill-Sachs defect, as you see. So in our protocol for Hill-Sachs Remplissage, this is the independent from the number of dislocation episodes. The glenoid bone loss should be lower than 15 with a Hill-Sachs deep and medialized defect and with the good quality of capsulolabral tissue. We go for the arthroscopic Bankart plus Remplissage in this situation. The last operation that we do is the bone block LATARJET procedure. If we have more than 3 points of ICSS score, if we have a combined bone loss, glenoid with the humeral bone loss, we choose the LATARJET procedure. As you know, the LATARJET was described from a French surgeon from Lyon, Michel LATARJET, and was modified by Didier Pat. And this is a surgery of triple block effect. Triple block means bumper, bony, and the belt effect. And the most important point of this situation, the surgery, is the congenital tendon sling effect, because it's very important to have a good end range and mid range stability with this sling effect. And the long-term studies show that the recurrence rate is under the 6%, and the functional scores were very, very nice. This is a 20-year follow-up study from Gilles Vache group, but we can see that the osteoarthritis can be seen 23%, but it is mild grade osteoarthritis, which cannot give any physical examination situation. So there are some complications of LATARJET. It is almost 25% and 10% of neurologic complication, but only 2% of the neurologic complication could be permanent. So it was described by arthroscopically by Laurent Lafosse in 2007. Then from another French surgeon, Pascal Boileau, described it with the Bristow LATARJET, the small piece of bone with the cortical buttons. And then Marcus Scheibel described the iliac crest arthroscopically. But as you know, the US surgeons use still the allografts, especially distal tibial allografts in their practice. So
excuse me, kindly reminding 3 minutes, Professor Bilsel.
Preoperative evaluation is very important. The mid-range apprehension test show us the bony defect, and also CT images, especially in the humeral subtraction and FAS view, is very useful for the measuring the bone loss. So we start to do this procedure open, and we learn it the open way. And then after 2012, I start to make it arthroscopically. These are the steps of this procedure. It's a very tough procedure, and the learning curve is very long. As you see, this patient, 31 years of age, male, the ICSS score is more than 5, bipolar bone loss with laxity. We choose, but interestingly, this patient has a rotator cuff tear also in a partially, and we choose the arthroscopic LATARJET for this patient, and we cut the coracoid bone, and we transfer from the subscapularis split, and we control with the switching stick if it is flush or not, and then we make a repair for the cuff in the same session. And this is the 2 years follow-up. We can also have some complications like graft lysis, as you've seen in this slide, total lysis. In this situation, we choose the Eden-Hibinet procedure, iliac crest bone grafting, for the revision of the LATARJET procedure. Why arthro-LATARJET? Because this is an arthroscopic examination of the shoulder. We can see the additional lesions. The graft positioning is good to see and to check. The post-op rehabilitation is early, and the pain and the cosmetic is nice, but about the graft osteolysis, we don't have any data in the literature. This is our study, the very recent study in arthroscopy. We compared the arthroscopic and open surgeries that we did, and we have some good functional results in open and arthroscopic LATARJET, and these two techniques provide the similar clinical and radiologic outcomes in our hands. So in bone block procedure, if we have multiple dislocation, if the patient have an easy dislocation history, and if you have more than 15% of glenoid bone loss in the failed Bankart surgery and bad quality capsulolabral tissue, we go for the bone block LATARJET procedure, and the revision setup, we use the Eden-Hibinet procedure. Thank you very much for your attention.